Thank you guys so much for joining us for this 2:15 panel on healthcare. I am Eleanor Klibanoff, the women's health reporter at the Texas Tribune. Before we get started, we should say this session is sponsored by Methodist Healthcare Ministries of South Texas, Meadows Mental Health Policy Institute, Blue Cross and Blue Shield of Texas, the Texas Hospital Association, Texas 2036, and the Office of Public Insurance Counsel. So thank you to our sponsors, and thank you all for joining us for this extremely important conversation. I'm going to sort of jump right in, introduce my panelists, the panelists. We've got Donna Howard, a Democrat who's been representing Austin in the House of Representatives since 2006. Representative Howard has also worked as a critical care nurse and a health educator, and served as a past president of the Texas Nurses Association, District 5. We have Steve Allison, a Republican who has represented North San Antonio since 2019. As an attorney, Representative Allison has represented businesses, doctors, and religious organizations, and served 12 years on the Alamo Heights School Board. And last but not least, Representative Collier, an attorney and small business owner. Collier, a Democrat, has represented the Fort Worth area in the House since 2013, and is currently the chair of the Texas Legislative Black Caucus. No, she was the chair. Immediate past chair, mere moments ago. Yes, it changed while I was printing. Anyway, well, thank you guys so much for joining us. This is obviously such an important topic going into the session. It's hard to think of any topic where more has changed in the last couple of years. And to start sort of big picture about healthcare access and the state of our healthcare systems in Texas. We are sitting at almost 3 years after COVID-19 first arrived in Texas. Our healthcare systems were a little battered and bruised before that even, and now we are facing significant workforce shortages, extremely high costs for hospitals and healthcare providers. I'm sure you all hear from your constituents about the trouble they have accessing healthcare. And a recent Texas Hospital Association study found that 1 in 10 Texas hospitals is at risk of closure. With all of that facing this state, what can and should the legislature be focusing on this session to try to sort of get our healthcare systems off of life support? Representative Howard, if you want to get us started.
Sure. I mean, that is a huge question with multifaceted answers that I'm sure we'll all kind of chime in on. But clearly, access has been an issue for a long time. And that has to do with a lot of factors that have been exacerbated by COVID. Certainly, we do not have the workforce that we need, and that's only gotten worse. The nursing shortage, the physician shortage, the provider deserts we have in our state, the closures of hospitals. As you said, we've had the most closures of rural hospitals of any state in the union. That is a real barrier, obviously. But then, of course, we've also had the barriers of not having expanded Medicaid. We have the barriers, quite frankly, I'll have to say that with that particular issue, we've got about, just ballpark it, 5 million Texans that are not covered right now. Expanding Medicaid would cover maybe 1.5, 1.7 million, something like that. So there's still several million that would not be covered even if we expanded Medicaid, and that has a lot to do with navigation of the system to find coverage that they can use, and not understanding that they can actually get something that's affordable. So part of the challenge there is having the navigators we have to have in place to help people access the coverage that they can get. So bottom line though is if you don't have some kind of coverage, you don't have access, regardless of whether there's providers or systems. You've got to have the coverage. So all of these things go hand in hand, and all of them require our attention. We can talk more specifically as we go on here, but really expanding Medicaid at this point in time should be something we should be able to embrace on a bipartisan basis and just do. It is something that will tremendously benefit our state. We're way behind the ball on doing this, and this is the number one thing we need to be doing this next session.
And we're going to get in the weeds on, the viability of that. But Representative Allison, any thoughts on sort of big picture, other initiatives you'd like to see the legislature take on?
Well, no, I think that access is just critical in all factors. Mental health, I think, is going to be a major issue that is also an access problem. I agree that we need to address Medicaid expansion. However, whatever we call it, but I think it's critical how we do it. I think one of the problems that we have with our access situation is we don't have enough physicians and providers across the spectrum. And I'm afraid that if we don't expand or provide additional Medicaid in a way that will attract more physicians back in the fold, and I think a fundamental part of that is that we have to increase the reimbursement rate.
Yes.
And I think historically, the states that have done that around the country have found that physicians have come back into the fold, so to speak. You know, we have a critical shortage of physicians in Texas. I think it's become a ever worsening situation, largely because of the pandemic, and a lot because of the reimbursement situation. So I think that's something we really need to focus on. And I have trouble, just in my view, but others I've talked to in the healthcare field, if we don't increase the reimbursement rate, we can't make it work.
Agree. That's exactly what I was going to talk about, Steve, is the reimbursement rate, because it's hard to get somebody, a healthcare professional, to participate when they would lose money and their business would end up closing. So we have to have the reimbursement rate and the adequacy of the network, so that way people can have access. So that means the health insurance companies, we need to make sure that they have adequate networks when there is coverage. Another thing is the totality of the circumstances. When we're talking about healthcare, stress plays a big role on the overall physical health of somebody. So if I don't have access to, an employment, the ability to take care of myself, my family with dignity, then that could have a negative impact on my health. So let's, traditionally, yes, I need to go to the doctor, but I need to be in good emotional and mental health, and I need to be strong there. So that means I'm, have a job, my children are, taken care of. So those are things that play a role, that I have access to healthy foods, and fruits and vegetables. These are all things that play into having, having good health care.
Right, that holistic health.
Absolutely.
Yes. Representative Howard, I know one issue you have tried to tackle in the past and have filed a bill again on relating to our nursing shortage is that workplace violence protection for nurses and like that piece of the puzzle. Can you talk a little bit about why that's a priority for you?
Yeah, absolutely. I think traditionally it's kind of been thought by the profession that it's part of the job. And, we're in a hospital setting in particular, there are just by the nature of who's in the hospital. You have people who have dementia, you have people who are on medications that alter how they're approaching things. You have traumatic situations with family members involved who are very upset. All kinds of things that create an environment that can be very difficult. I myself was attacked by a patient in ICU back when I was working there. I know Stephanie Click, another rep from Fort Worth, that she had a gun pulled on her at one point when she was working. This is a common thing that happens in hospital settings, and we know, unfortunately, that it can turn very deadly. But just the day-to-day can be very difficult. And so over the years, we've tried to work with creating policies that would protect nurses and other hospital staff members and set up some policy committees and that sort of thing. But we really just didn't have the enforcement mechanism in place. And we have come to some agreement. The Texas Nurses Association, the Texas Hospital Association, the Texas Medical Association have all signed off on this legislation, which will give more emphasis to making sure that the policy committee is working, has the policies in place, has the training, is going to have interventions available if indeed something does occur. It's just a more robust way of addressing it. But the main thing is that it has all the stakeholders signed off on. So hopefully, we had it last session. It just didn't, the timing ran out and we didn't get it through, but hopefully this time it can be a priority because clearly the workplace setting is also a factor in retention of staff. And COVID made things worse with violence as well. And we've got to do everything we can to help ensure that we have the healthcare personnel we need, because clearly we all need that. When we need their services, it's extremely valuable, and this is one of the ways that we can help address that.
Great, thank you. As all three of you mentioned, Texas is now one of just 11 states that has not expanded Medicaid. We have the highest uninsured rate in the nation. The top 5 highest uninsured states all have not expanded Medicaid. Last session, you all, supported this legislation, the Live Well Texas program that, was maybe as close as we're going to get to Medicaid expansion. Representative Allison, can you talk about, as a Republican, that bill did have bipartisan support. What appealed to you and some of your party members about that versus, the more traditional Medicaid expansion? And do you think we might see any similar momentum this session?
I hope so. We had very few of us on the Republican side. I signed off on that bill and worked quite hard on it. Again, the fundamental piece in my way of thinking was the increasing the reimbursement rate. I think that had to just be the starting point. Because I've often used the example, and nothing against Iowa or Indiana, but we're not Iowa or Indiana. We have far more people and far fewer physicians and providers. So I think the only solution is to address that problem and increase the reimbursement rate so we can have more providers and more physicians that are necessary to cover the influx of Medicaid recipients. And then beyond that, I think what may become more attractive to the Republican side anyway is if we put in a wellness incentive, if not a wellness requirement. And I know we're working on that now to see if we can't adopt rules or provide a rulemaking authority where there'd be a wellness requirement for the recipients. Because I think we all benefit from that. If we have a healthy and well populace, whether it's Medicaid recipients or otherwise, we all do much better with that and costs come down. And then in addition to that, some sort of workforce or job incentive or requirement, because if we can get people back employed, recognizing that some of the Medicaid recipients just are going to be incapable of holding a job or seeking employment, but those that can, I think, again, we benefit if we get them onto a private plan or employed and healthy. We all benefit. So I think those are the type of approaches we can make, and I'm cautiously optimistic we're going to see some movement this session.
That sounds really good. However, the wellness for the recipient, okay, I can understand that, but if we're going to have a job requirement, then maybe we need to also make sure that they have access to childcare that's affordable. So, I mean, if we're going to put parameters or put measures in place where you can, I guess, measure the outcome or, the quality of it or the effectiveness of it, we got to think about how it actually works on the ground. Because it sounds good on paper, but then all the ripple effects. So I'm required to work, but then I can't get childcare. Then might as well stay on assistance, because that way I'm not breaking any rules. I can just, so I think that we can't get in the way of ourselves. We have to make sure that it actually works and it does what it's intended to do. So the wellness incentives on the individual, I think that we're expecting, if we're I don't want to put too much on the individual, because if I say you have to comply, well, I want to comply, but the pharmacy, the medication there is so expensive, or the doctor's office is far away. So let's, if we're going to talk about having compliance issues, because this is one thing I did learn. I didn't realize how personal medical professionals take compliance. They feel like it's something on them that if you're not complying, and it's not always you. It might be something that I am dealing with in terms of my circumstances. Like I have to drive, 600 miles to get some healthcare or something like that. I can't come back to the doctor for the follow-up. So are we going to penalize the physician, the hospital facility, and the individual because of their location, because of these circumstances? So we have to be mindful, and that's where you guys come in. And you tell us, hey, look, that sounds good. And of course, I understand the responsibility, the fiscal responsibility behind that. However, when they're in these situations, it may not work that well. So.
Do you have anything else to add on that? Or
No, that was great.
Okay. Last session, we did see similarly some momentum, at least initially, around expanding postpartum Medicaid for a whole year after someone gives birth. Made it through your chamber. The Senate knocked that down to 6 months. That is now sort of stuck in bureaucratic limbo. Representative Collier, what do you think are sort of the odds of us getting that year, and why is that important from your perspective?
Well, it's very important. The maternal mortality rate for Black women is exceedingly high, and I'm disappointed from the report that we just got from HHS, which it's not even the same as the one they gave out last year, but I think they're going to come out with some more information, because they don't distinguish the rates between the race and ethnicities like they've done in the past in this current report that just came out the other day. And the recommendations to address maternal mortality are not, I don't think that they're finished. I think that there's some more information that they're going to share with us. But having access for 12 months is very vital, because we don't have evidence that within those extra 6 months there's fraud. No, we know that there's compliance. There's better compliance when I have that coverage for myself 12 months after the birth of my child. So definitely making sure that those 12 months happen. The system is going to be fine. We already have things in place that would identify fraud. So I think that is very key, and I feel like we are very close, and that we will get that, especially with this $27 billion that we have extra to deal with. But I feel confident that we'll be able to get the 12 months for this next session.
Would you like to add something to that?
Yeah, I mean, the Maternal Mortality and Morbidity Review Committee, this was their #1 recommendation. And that's the folks that we have tasked with looking at this issue. And that's what they have been recommending since they've been making the recommendations. So it's also a recommendation at the national level. And in fact, part of ARPA included some incentives to expand to 12 months. And if you expanded to, the typical has been 2 months. That's what has been the minimum requirement by the feds. And we were only at 2 months postpartum, you were off the program. But the federal government wanted to extend it to 12 months because of the medical outcomes, advantages of that. So ARPA said that if you do expand it to 12 months, you don't have to do a waiver. You can just amend your state health plan, which is a lot less bureaucratic, it's more expedited. It would have assured that we could have quickly moved into this. But because we applied for 6 months, and that wasn't the recommendation, and because of some language in the bill, the federal government refused to approve our 6-month waiver application. And so we still are operating under the 2-month, except for the fact that because of the public health emergency, everybody that was on Medicaid when the public health emergency was declared back March 2020, they're still on. So anybody who was on the pregnancy Medicaid program back in March of 2020, instead of getting kicked out at 2 months, they're still on the program right now. They're still getting covered by Medicaid. And to me, that is a unique opportunity for us to look at, has it changed the health outcomes of these moms who stayed on now for a couple of years? Did it make a difference? And we've asked the agency to try to help us determine that, and we're hoping we get something that will show it, because clearly not having to find a different program, a different provider, the gaps that occur, that didn't have to happen this time. So did it make a difference? I would suggest that it probably did. I'm hoping we'll be able to find that out.
Yeah, absolutely. I mean, I've talked with providers who've talked about, women have been able to stay on in between virtually the entire time in between their pregnancies, and like what a difference that makes.
Exactly. One of the most significant public health events of the last century was family planning. And the reason for that is when you space your pregnancies, you have a decrease in maternal and infant mortality. Huge thing for us to have that ability to space pregnancies. And this has been a way they've been able to have that continuous coverage, be able to get contraceptives, be able to have the health care they needed, so that hopefully they weren't having the pregnancies too close together, which was going to be more dangerous.
Representative, oh yeah, please.
And it seems like what we've been missing is, access is just part of the situation, and outcomes is what we're really after. And it seems like the 12 months is a no-brainer. As Donna said, that would have made life much easier if it came back to the state system. 2 sessions ago, we passed a similar bill in the House, and it didn't see much life in the Senate. This last session, we passed the 12-month in the House, and the Senate cut it back to 6 months, and I think we accepted it out of desperation that something was better than nothing. But I've yet to hear really a solid explanation from the Senate as to why 12 months wouldn't work. So I'm very optimistic we're going to go back this session and get it to the 12 months where it needs to be.
Right, right. And that's certainly a thing that's changed. I mean, when we passed 6, it was easier to say, well, we're ahead of some states. And now a lot of states have passed 12 months, so we're sort of suddenly behind the ball on that, right? We've talked about or alluded to the maternal mortality report. Texas has above average maternal or above the national average maternal mortality numbers, which is saying something in a country that has the worst maternal mortality numbers in the developed world. And we know that maternal mortality disproportionately affects Black women and Black people. Representative Howard, can you talk a little bit about, with the status of that report that we do not yet have, and sort of what that delay will mean for legislators?
Yeah, and it does turn out that tomorrow morning, the review committee is actually meeting, and we'll be getting some kind of an update from the new dishes commissioner. So remains to be seen. We'll see what happens tomorrow. But at this point in time, we still don't have the actual report, even though it is required in statute that this report was to be distributed September 1, which it's a whole nother issue, but it points out the inadequacies of our system where with a part-time legislature, we have no capability of enforcing things between sessions. If we're not in session, there's just nothing we can do. We send letters, we talk to the media, bring attention to it, but the only person who had the ability to do anything about it is the executive of our state, the governor, who also appoints the commissioners and could actually demand certain things of them. But this draws us to a problem here when we're talking about a statute that says you shall do this and it's not done. The fact is we still don't have it. We did request some additional information about an intervention done with obstetric hemorrhaging, which is one of the leading causes of mortality and also severe morbidity. And we did get that information. So it did give some of the stuff that Nicole was referring to.
This report?
I can't see without my glasses, so.
They did release a report.
Talk about health issues.
Yeah. Look, I put my glasses in my purse. I got it right here.
Anyway, the fact is that was an intervention that was done that is a great thing that's been being put in place. A protocol to have hospitals prepared and ready to intervene with some best practices. And it has made a huge difference with outcomes. It significantly reduced the complications of obstetric hemorrhage across all of our population, except for our Black moms. Theirs actually went up. And so part of the concern we have and why we want to see this is, well, for one thing, what the heck's going on here? Because we don't know how to intervene and put in place those things that are going to address these issues. But also there's concern that we are actually seeing the implicit racism, the biases, whatever it is, that is making sure that the Black moms are not getting the same kind of outcomes that all other moms are getting. And this particular report also, for the first time, has some kind of a factor that they've built in that looks actually at racial disparities. So we really need to see it to know what we need to do, because the whole point of this is to keep moms alive and to keep them healthy. And we have to have that information to know what policies are going to give us that kind of an outcome.
Representative Collier, were you saying?
Well, I was going to say they did release a report, and in it, it's only 34 pages. Typically, it's 74 pages, but I had to really do some digging to find it on the HHS website. It's dated December 2022, and it's the same title: State Efforts to Address Maternal, and they added depression, mortality, and morbidity in accordance with the same statute. but it's still different, and a lot of it says, we will update. So, I mean, they did do a report, okay? In your face, I mean, literally, like, we did it, but we're gonna update it. So it still needs to be, completed. It needs to be final, so that way we could take action going forward.
What actions would you like to see? I mean, I know it's hard to say that without the recommendations from the committee, but.
Well, that's where, exactly. We need to see what they found to make appropriate adjustments within the healthcare system, because that's what they're tasked with. They're tasked with identifying the gaps, showing where we're strong, where we need improvement, and from there, we can make adjustments, and also hearing from the stakeholders, the providers, the actual people that are in place. You look at this report and you say, oh yeah, that's true. This is what we could do to address that. Less paperwork, more actual, maybe the pharmacy stuff is too much, the prescriptions, things like that. More telemedicine, I don't know. We just need to see that report to help us make those adjustments and follow those recommendations. And funding, we need money. We need to fund these programs.
Sure. Representative Allison, I know there's been a lot of attention on maternal mortality in the last couple years. Do you see that as an area of potential bipartisan collaboration? Is there interest in your party in sort of working on these issues?
Oh, absolutely. I think that's inescapable. I think that's in everyone's best interest. And I think there's just several pieces to it. Expanding to 12 months, I think, is a piece of that. Back to the wellness concern, I know it's one of our sponsors today, but in my area in San Antonio, Methodist Healthcare Ministries has done a tremendous job by setting up clinics throughout the greater San Antonio area, but also into South and West Texas. To provide better access, that hopefully it'll provide more patient access, and there'd be some ongoing treatment without the onerous burden of having to travel a great distance for care. And I think that's an important piece. And then, of course, funding. We're going to have this ungodly surplus this session, and I think we need to use it in areas that help everyone like this.
Thank you. That's probably a good segue to, my favorite topic to discuss, perhaps not y'all's, which is the current state of the abortion laws in Texas. And, Texas already has, as we said, a very high maternal mortality rate. There are some, researchers who are doing some early projections, and as we've seen in some other countries, that there are often, negative maternal health impacts when abortion becomes more restricted. Representative Howard, can you talk about sort of what you are predicting, to the importance of this maternal mortality information in that landscape of reduced abortion access?
Sure, a couple of things there. One, we do keep track at the state level of complications related to having an abortion. And that report over the past 10 years, there's been one recorded death due to an abortion without any information about what the implications were, so I can't speak to that. But over that same period of time, of course, there's been hundreds of moms that have died due to pregnancy. So we're talking about at a very basic level, not having a choice about something that can actually result in death. We also know, though, that over half of the births currently in our state are paid for by Medicaid. And those people who will not be able to access abortion health care by traveling out of state, taking off work, finding childcare, because the majority of abortions are to those who already have children. But doing all that logistical stuff, you have to have a certain amount of resources to be able to do that. So it's going to be those that have the resources will be able to travel out of state and go to a state where it's legal, unless the legislation comes through that tries to prevent our travel, which is being talked about. But anyway, that means that the people who are going to have these unwanted pregnancies are going to be those of limited means, which also in our state, because of the way the economy is here, disproportionately impacts women of color and rural women. But they will be the ones that will be having more babies. So we can anticipate, and we have asked again also for these numbers from LBB and from the agency, what do you anticipate the increased number of births are going to be to Medicaid in our state? So there's a lot about the funding issue we've really got to be looking at here in terms of supporting these moms and their babies. I say that to my colleagues who label themselves as pro-life, that this is the outcome of that means we're going to have more babies and more moms having babies, and let's show that we can support those moms and babies by funding the very programs that are going to allow them to have healthy births and to be healthy after they have their births, and that those babies will be healthy too. So one of the things that we're recommending, and hopefully we can do some things on appropriations, but we want to double the money for the federally qualified health centers, because that's one area where anybody can access those clinics that, like you're talking about, and get the health care they need. We've got to have more of those in place, and we've got to have them all over the state. We need to look at mobile clinics. We need to look at telehealth and telemedicine. We need to look at everything that we can do to support these moms and babies, because we're going to have a lot more of them. We're not even supporting fully what we have right now. Mm-hmm. So that's really where I'm seeing a lot of what we need to be doing and how we could all be working together on this.
Right. And so just to piggyback on what you were saying, Donna, I'm not sure that Texas is ready for the economic consequences of what we're about to see. And of course, I would like the data too to see about the increased births. But when you're talking about mandating, having a gestational mandate for someone who's been traumatized, that could re-traumatize that individual. So we need to make sure that our behavioral and mental health programs are in place, that they are funded and they're available for individuals. So I'm concerned about that. And we already have a foster care system that has been ruled by a court to be dangerous. So why are we, setting a child to be into that system, for our program, which is not in a good place right now. So we need to do more to address our foster care system, make sure our mental and behavioral health funding is getting into the hands of those that are providing those services. So I think that, and then jobs, we need to make sure that we have opportunities in our education system, literally. I mean, I can go on and on about how this is going to impact just about every industry, in Texas.
Just one addition. I think one area that has not received the attention, publicity, marketing, whatever, is the alternatives to abortion provision that we passed last session. And I think that has $100 million in it, which I believe is inadequate. But the details of that, I think, really need to be explored and enhanced. It includes extensive counseling, job placement, housing, food, clothing. I think the more we can do there, dealing with the situation, the better. And I think all the things we've been discussing so far, whether expanded Medicaid, whether the increasing to 12 months, I think all goes towards that increased attention to pregnant mothers.
Well, there's a lot to talk about there. First off, alternatives to abortion. If abortion's illegal, we don't need alternatives to abortion. Mm-hmm. We don't have abortion. These programs that have gotten funding, and I understand how it's been discussed and portrayed, but when we look at trying to get metrics and accountability, it doesn't exist. And the fact is that part of the metrics have been handing out pamphlets. Seriously, you get a mark of, this is how many units of things you've done. Handing out a pamphlet is equal to providing 20 minutes of counseling or whatever it is. It's an unaccountable program that does not have medically accurate information, that has been used as a portal for getting people to who are pregnant to not have an abortion and instead carry the pregnancy. And they do provide some opportunities for some job placement information, parenting information. They do provide some diapers and car seats and those kinds of things. Those things can be provided by a wide variety of social service agencies. These are not medical facilities. They don't provide any health care to these people who desperately need health care. Those dollars could be much more effective in the healthcare system to actually provide healthcare to these people and get them what they need for healthy pregnancies. I have visited one here in Austin. Good people, good-hearted people trying to do good things, but it's not, to me, an effective use of our taxpayer dollars. And if we're going to have any kind of a program like that, we need to look at what already exists in social service delivery programs and help those be more effective. get these people into the Healthy Texas Women's programs, any program that we already have that exists, get them into these programs, the nurse-family partnership, those kinds of things that actually can make a difference and actually have evidence-based outcomes. And the final thing I'll say is that there has also been evidence of some misappropriation of funds. There is just not enough scrutiny of this program, and for me to in any way come near to having said that this is a program we should continue, much less add money to, there's going to have to be a lot shown to me about accountability before I would ever go anywhere near that.
And yes. In fact, I had just learned that they don't have healthcare professionals running these facilities. And I was told it was a sham. This is just a basic sham. But what I do appreciate is all the contraceptives that they provide. You know, the condoms and the birth control pills, right?
No.
Oh, no, they don't even do that.
Mm-mm.
Oh, okay. So, again, this is, if you're talking about alternatives and helping people have a family planning, that has to be built in to any type of program.
And why isn't it? Why can't it be? That's what I'm saying. I think that program need to be enhanced. And I agree with you fully. There needs to be more accountability and transparency. But I think that is a viable alternative to explore, and better fund, better oversight. I agree with you. I question some of the subcontracting that's been going on. I think that's one of the fallacies in the program, the way it exists right now. That it's just subject to the whims pretty much of the subcontractors without the necessary oversight. But that's why I think if we funded that better and more efficiently, I think it'd have great benefit.
And Plan B?
Pardon?
Plan B, would that also, I know I'm pushing it too much. Huh?
Representative Allison, I know you have said before the election, you said that you were interested in potentially hearing the legislature consider adding a rape and incest exception to the current abortion ban, which provides which is a near total ban except to save the life of the mother. Is that?
Yeah, I'm certainly open to that being considered. I think it was unfortunate it wasn't. The only bill or proposed amendment came late. It was a Republican, my friend Lyle Larson, and it didn't even get a hearing. So I think it would behoove all of us to explore that better. I noticed, read a blurb this morning that the Lieutenant Governor is even non-committal on whether it should go forward or not. And I know there's interest to do it. And I think that we need a full hearing and discussion, not just the emotion that's going back and forth from both sides on the issue outside of that. And we've never had that on the House side anyway. And I don't believe the Senate's come close to it. But I think that'd be very valuable to explore and see the pros and cons of adding rape and incest exceptions and what the details might be. Yeah, I'd be fully supportive of that.
Add to that, yeah. I think one of the concerns, if we could even get near doing it, as you point out, I don't even know if it's possible, but is to not re-traumatize the survivors. We know that the studies have shown here at the University of Texas that only about 9% of those who are assaulted actually report. Mm-hmm. And one of the reasons for that is because oftentimes the person who did the assault is a family member or a friend, or somebody who lives in your home, and people don't want to report that. And the concern is that there would be a requirement for reporting in order to get the abortion, and that would be forcing a survivor to do something that re-traumatizes them. And so there's a lot around this that has to be looked at very carefully and not have unintended consequences to it, because personally, my opinion is that I think those who have been assaulted should have the right to terminate a pregnancy that's the result of an assault. That being said, I don't think they should have to report it in order to do that. And so I'm not sure how this would come out, but there's a lot we're going to have to think about as we talk through this. And then I guess just going even back to pre-overturning of Roe v. Wade, the concern then was, do you have to be assaulted to be able to seek an abortion? That's the only thing that justifies your being able to seek an abortion if you've been assaulted? There are other reasons that people seek abortions. And there was a concern about limiting. Now that's almost moot at this point. So now we're looking at, again, a lot of it's looking at how do we make it less bad?
Right, I mean, and so Representative Allison, as you mentioned, Lieutenant Governor, Dan Patrick wouldn't even really commit to considering a rape and incest exception. In fact, said basically, I'm not saying no, but, which, is as close to no as I think you can get. But from your sense, is that sort of rape and incest, is that going to be the furthest reaches of the conversation in one direction? And I mean, where do you think the conversation around abortion from your party may go in the other direction in terms of tightening those laws further or making sure they're being more strongly enforced?
Well, I know there have been some bills pre-filed that go in that direction. I don't see them succeeding myself, but I know they've been filed, and I think we need to counter that. So I agree with Donna that there's so many parameters and tentacles to this. I think we need to be very cautious, and that again, that's why I think it needs a full hearing and discussion in committees.
Great. Well, we're going to talk a little bit about mental health, but once we do that, we are going to open up to questions. I think we've got mics on either side, so if people want to start lining up while we do that. We just have a couple minutes, and this is obviously could be its own panel just to talk about mental health and the importance of that. But going into this session, there's so much conversation around mental health, so much attention on mental health after Uvalde and other similar circumstances. What do you hope the legislature sort of comes together on and comes out with, at the end of this session on mental health that would feel like a real victory? Representative Collier, do you want to start?
Well, a lot of the groups and facilities that are on the ground, they have wonderful programs already in place. They just need to have help funding them, expanding them and access to them. But actually providing information and education to individuals, we've done a good job in Texas of removing or reducing the stigma associated with mental health treatment. And so we need to keep that going in terms of letting everyone know it's fine, it's okay to not be okay, and it's okay to get help. So I think that that's something that we need to continue to grow, that education piece, but the funding and at every area. I mean, we got to get it into our schools. We have to have, these are things that we could do within the school systems. Our churches, being good partners with our churches, anywhere you can go. I remember one time my daughter, she worked at Target and she was checking somebody out. And at that point, that person wanted to share. At that point, she's like, I'm not equipped to take this trauma, but literally we need to have people in place, whether you get your nails done, your hair done, maybe there's some things that we could do to help, be in that place, be that right person to connect that individual with the right people. We just got to think outside the box.
Right. Representative Allison.
This is an important area to me. I think it's an ever-increasing problem and situation. I've often said I think it's unfortunate we call it mental health because it's so much broader than that. And the connotation that, well, I'm not crazy, I'm not sick. Well, it's so much more than that. Whether just anger, propensity to violence, whatever. And we see it through the pandemic. It's been exacerbated. We saw it through the Uvalde tragedy. We've had the structures in place. We've identified it in the past, but just haven't done enough. We did a lot of work on the Children's Mental Health Consortium that I think was an important piece of legislation, received a lot of pushback and opposition, but I think we're seeing now how valuable that legislation is, and it needs more. We've sent up mental health resources through TEA that's set up through the educational service centers. Unfortunately, it was very slow to get in place. We passed it 2 sessions ago, and it was just this past spring when it was finally implemented and ongoing. I think that has proved to be very valuable, along with the consortium, that it's intended to deal with the students and children, but I think we're finding that if we can get the children involved, the counseling is showing that it may not be the child, it's something else in the family or the parents or some other part of the environment that I think is very beneficial. But I think we need to put far more funding into additional facilities. We saw that with the Uvalde tragedy. There's a total lack of facilities and services provided, and particularly in the rural areas, that I think we need to shore up. We can do a lot more with telemedicine. We've done some major steps in that direction, but it's broadband sensitive. And so many parts of the state that really need that don't have the broadband capabilities. I think we're dealing with that separately, but I think we need to expedite that process. So they're just some of the thoughts. You know, we're seeing that the suicide rate is going through the roof. Children, the pandemic contributed to that tremendously. First responders, we saw that the retired first responders had a high suicide rate. Now we're finding that it's coming down into the ranks, the active duty ranks of first responders because of what society has done, the economy, the pandemic, everything, that we need to provide much more focus on mental health issues.
Thank you.
Yeah, the broadband, just to give a point to that, the latest number that I heard from the comptroller's office, where the broadband office is housed, is that we have 7 million Texans that still do not have connectivity. 7 million, that is a lot of Texans. And we know from what happened with COVID how much we're dependent upon that now for healthcare, for education, for employment, for all kinds of things. So yes, we need to expedite that. I think one of the things that we could use our surplus dollars for is to expedite that process. But I was really glad to see the Lieutenant Governor mentioned additional psychiatric beds in his press event the other day. Clearly, we need more beds. We also need more different types of facilities, though, as well, for partial hospitalization and community homes, halfway houses, quarter-way houses, all the different ones that the step downs that we need to have there. We just do not have them. And again, it goes back to what we talked about at the beginning, providers. We don't have the providers. So we've got to do everything we can to incentivize people going into the mental health care field. Certainly psychiatry is a huge shortage, but I'm also talking about the other providers as well. And with schools, oh yeah, that is such a huge issue right now that you brought up, Steve. You know, the Surgeon General has issued that it's a public health emergency, the adolescent mental health situation, and with the increase in suicides. This is really tragic stuff that we're having to be paying attention to. And, you know, school funding is going to be a big part of what we're going to talk about this next session. We made some headway last time about ensuring that counselors had more time to actually do counseling, but we still don't have that really in place, and we're still way behind with counselors in our public schools. There's so much that needs to be done here, and I guess my bottom line expectation and hope is that rather than just going out there and throwing things at different things to say we did mental health, that we'll actually look at this real strategically and think about what's the best way we can invest in this issue across all our agencies, across all industries, whatever we need to do here. How can we take a holistic approach to this, use this unique opportunity we have right now with everybody focused on this issue? It's bipartisan, we're all focused on this issue, and we have this surplus. What can we do that will really take us further down the path than we would ever have had an opportunity to do otherwise? So it's a real opportunity. I hope we'll take advantage of it.
Great, thank you. We'll now go to questions, as always, you know, questions come with a question mark at the end, and we'll ask you to, be as succinct as possible. Do you want to start over here in the blue?
Hi. I just wanted to talk about, there's another side to abortion that most people miss, as it was not discussed. There's a disregard for expectant mothers who have abnormal pregnancies where their babies are terminal. We're talking about traumatizing mothers, and that is a traumatic experience, especially for babies that are wanted, which those are. They don't have a choice anymore. I'm really I want to know, are you okay? And I believe everybody deserves a choice. If you are raped, if it's incest, no matter what, you have that choice. But is that something that's on the table? Are you okay with removing the choice for someone to humanely end their pregnancy if their baby is terminal?
Let me start real quick, and maybe Steve has something to say about it too, but we're definitely looking at that issue, and we're working with the physicians to come up with clarifying language that takes away that ambiguity that has prevented the physicians from feeling comfortable without the fear of liability and even losing their license and even going to jail if they don't follow what they think the law is being interpreted to say. So indeed, yes, totally agree with you that that's got to be addressed. We've had so many instances that have been reported to us and have had physicians tell us that we are having to wait for women to start dying before we can do things. Now, that's the maternal complications, but then there's also the complication of fetal abnormalities. And whether or not with a non-viable fetus, we should require that someone go months with that non-viable fetus, knowing what the outcome is going to be, is indeed traumatizing. So how can we look at all of these things, and hopefully we'll be able to make some headway, because I'm hoping it's unintended outcomes here that we're talking about, but it is definitely hurting a lot of Texas families.
Representative
Yeah,
Allison?
no, I agree fully. I can't believe that was the intent of the bill and act. You know, and I think it extends to the concern over a miscarriage or necessity for a DNC. I don't think that was intended to be an abortion situation that the physician would have any questions, but obviously they do. So I'm confident that needs to be addressed and will be addressed to clarify.
Thank you.
Someone over here?
Yes, thank you so much for being great models of civility in discourse and collaboration on these issues that are facing us. In Austin, the sitting state senator, Kirk Watson, is very concerned about childcare for Austin, Texas. He's running for mayor. And I was wondering, do you have any information, or that's a tangential issue to the gestational mandate. I don't know if you have information you can share about childcare.
Sure, yeah,
Better
the
child-
child care shortages.
Well, I was going to say that there's some programs within our Texas Unemployment Commission that fund child care programs to expand access to it. So and actually the pandemic is what really exposed the shortcomings for it. And so we started shoring up that program. But absolutely, you know, we have that RISE program where you try to get child care facilities to participate and take individuals, but the rates of payment, you know, I think you can only be absent 10 days or something like that, and then payment stops. But we all know that life happens, and if it's a child, you know, a cold gets spread throughout everybody, and 10 days is nothing, you know. So we have to shore up that program. But absolutely, I'm open to, you know, suggestions on how we can make access to childcare more affordable and accessible, because not everybody works the traditional 9 to 5. Some people work overnight or late night, so we need to also take that into consideration.
Thank you.
Hi. For context, I graduated from high school in May of 2021, and the law in Texas right now is that students are taught abstinence-only sex education, and with the intersection of healthcare and education policy, I'm wondering if the state will actually put in provisions to talk to students about how sex education actually functions, because as a student who attended a Texas public school, I was quite literally taught just to wait until marriage. And with the new policies we have in this state restricting reproductive health care access, I want to know if Texas students are actually going to be educated on how their reproductive health care systems function.
Well, that has been a challenge in our state. We do actually have programs that can be taught that are abstinence plus, but a lot of the school districts don't have any sex education, the surveys that have been done, and many of them do just teach abstinence only. So it is a challenge when we have, especially with the environment we're in right now, with limiting what schools can and cannot do, and some involvement in what's being classified as parental rights. Certainly sex education falls under that, but right now we already have review committees in schools. Parents have opportunities to have their child participate or not participate. The idea is to try to have age appropriate information provided that could be used for healthy social behavior for young people. And there are curricula that we have. Healthy Futures in your neck of the woods in San Antonio, Healthy Futures has been really big on developing curricula that is evidence-based, age-appropriate, and has positive outcomes. So yes, we need to be doing more there and ensuring that you have the education that you need to be healthy, to be able to make good choices for yourself, and to be safe. So I hope we can do more. It's going to be difficult, I think, in this upcoming legislative session to do more.
a piece of this adjacent is you are yet again trying to get the state to add contraceptive coverage to the Children's Health Insurance Program.
Yes, we are one of only 2 states in the country that does not reimburse for contraceptives for our youth who are in the CHIP program. The other state's Nevada. So this means that all of the red states, the conservative states, have seen the value of this. We have one of the highest teen pregnancy rates in the nation. We have the highest repeat teen pregnancy rate in the nation. It's fiscally responsible to reimburse because that means we get a 90-10 match from the federal government. What we're having to do right now is to send these young people to a family planning clinic that is paid for 100% by the state, if they even have one in their community, if they can even find that. So what we're doing is we're taking away the opportunities for these young people who are trying to find a responsible way to not get pregnant and not reimbursing for it is just makes no sense when this is something that we could do to help address this issue. We've gotten it through the House before on a bipartisan basis. Again, it's the Senate that we've had a problem with, but I'm hoping we are getting some positive comments now that hopefully we're going to be able to get it through this time. I'm trying again.
Do we have someone over here?
Yes, thank you. What was the justification for the elimination of $211 million designated for mental health services, and how will you structure legislation going forward that these kinds of cuts will never occur again?
You're on approach.
Okay, I'm on approach. I'm not sure what you're referring to, but it may be you're talking about the money that was shifted around for...
The governor.
Yeah, yes, that the governor did with an executive order for funding
Yes,
other...
ma'am.
Yes, okay. What I can assure you of is that it's a net zero impact here. Okay. That part, the money is there. It was a how to do this. Taking money from one pot and putting it in another pot and switching things around is the best way I can explain it. It was a complicated process that had to do with federal COVID funds and FEMA reimbursement funds and substituting this for that, right, so that the money could literally have, he could legally do it. Mm-hmm. But the dollars were taken, in a sense, from what you're talking about, but those dollars were replaced with other dollars, if that makes sense. Mm-hmm. So, but a whole other issue to talk about one day is executive authority that the governor has, because we are a part-time legislature and he gets to do whatever he wants to in the interim. And because of public health emergencies and public health orders and disaster declarations, he has the power, even though we're the appropriators, he has the power to move money around without our involvement. And
line item. He can do line item for the budget.
Oh yeah, you can do that, yeah.
But if it's a bill, he vetoes the whole thing, but the budget he can take from pots.
He was actually able to move money, though, from one strategy to another, from one agency to another, do what he wanted to with that because of his executive authority during a disaster.
Great, thank you. We're gonna do the last question, and then, sir, maybe you could ask if we have, real quick, last question.
I know that Governor Abbott opposes expanding Medicaid. I'm curious if the legislature has a plan to circumvent him if you guys decide to expand it.
Go, Steve.
Veto proof?
You mean you're afraid he'd veto it if we passed legislation?
Well, I know that you can also bring the vote to the people. We could decide, and like 70% of Texans are for expanding it. So.
Well, and I think I may be mistaken, but I think a bill's been filed to do just that.
Okay.
Yeah. That's why I'm cautiously optimistic that if we can move towards, like I said, the increase in the reimbursement rate, the wellness incentive, however we characterize that, and whatever details we put in that, and a workforce position, I think we move more to the, I'll admit in my party, to accept that, and I think that would include the governor. I think we're to the point here, there's a lot of money involved that I think that if we do the increased reimbursement rate, it will pay for itself. Plus, The Biden administration, if it's still on the table, at the time there were 12 states that had not expanded Medicaid. Now it's 11, but he had offered an incentive that to Texas would have meant an additional $5 billion over the following 2 years that I think further sweetens the situation. When it's on a 90-10 split, I follow the concerns that if it's just straight expansion of Medicaid, the 90-10 could even backfire. And that's why I think the increased reimbursement rate and these other incentives would work. And I'm hopeful that the governor would see it that way as well.
All right, we're going to do one last question, sir, and then wrap it up.
Thank you very much. I run a healthcare nonprofit. For the vast majority of people under age 65, health insurance is tied to employment. We're worried about reimbursement rates because we have to use that in order to cover the cost of care for people who are uninsured and growing in numbers of people who are uninsured. And our premiums as an employer are skyrocketing, which I imagine is happening for every other employer. What can the legislature do to allow small employers and nonprofits to band together to purchase commercial insurance and reduce the number of people who are without coverage?
Wow, that's great. And I know there have been some discussion about that. Dr. Oliverson has tried to do some things with that. But one of the things that I've been involved with, and I would like to see it expanded if we could, is the TRICARE model, where the state puts in a third, the employer puts in a third, and the employee puts in a third, basically, and tries. And this is a way to help small businesses hopefully be able to afford the coverage that's necessary for their employees. So I don't know what the answer is, but you bring up a great point, and hopefully we can do some work to address that.
We moved in that direction last session by adding the Farm Bureau and Texas Mutual as additional lines to directed really at small business to start in the movement towards addressing your exact issue. But and I agree. I think Tom Alverson is working on more in that direction. But I think it's certainly an acute need we need to continue to address.
Great, thank you. Thank you guys all so much. Let's give a round of applause to our panelists.